So I live in Colorado, and people often think that Colorado is the mountains. I do not live in the mountains. I live at the base of the mountain. I live in the plains area, the Front Range. So it's a lot of fields where I'm at. But this is in our town. It's a city park. It's the Garden of the Gods. So I don't know if you've ever heard of it or seen pictures of it. Right here is the Kissing Camel formation. And so it's just a really nice park with these red rocks in them to go walk around. And then back here is Pikes Peak, which is a 14,000 foot. We're at about 7,000 feet elevation where I live, and another 7,000 to get to the top of Pikes Peak. This is where there was a school teacher I don't know if she was a I can't remember off the top of my head right now if she was a school teacher or a college teacher from the East Coast that came over and went to the top of Pikes Peak and wrote America the Beautiful, because she looked out and she saw the purple mountain majesties and all the aspects of that song. It was originally a poem that got converted into a song. So really interesting story um, about Pikes Peak and America the Beautiful. So you can drive up there, which we did once when we first got here, and it was really freaking scary, even as the passenger. All the like twists and turns and the narrow road. You can also take a cog train to the top, which we did this past fall, but we couldn't. It was November and we couldn't get to the top because of the snow. So, anyways, Colorado Springs has a lot to offer. If you're looking for a vacation in Colorado, that's not all mountains. All right, so as I said, we're moving on to the second half of GI. This is how I imagined you all looked taking your exam yesterday. You got your little tongue hanging out with concentration, trying to figure it out. This is an oldie but a goodie picture. And then this is Thomas walking in that Garden of the Gods. So you can see just how tall those rock formations are. But I think students do find this section a little bit harder than the first section because there are a lot of topics. There's pancreatitis, there's drug-induced GI disorders, there's peptic ulcer disease, irritable bowel syndrome, and nausea and vomiting. So that's a lot of topics to cover in 2 weeks. But just curious what you're most interested in learning about this section, and maybe a little bit why. You can answer privately in the chat, or you can shout it out.
I was gonna say IBS, irritable bowel syndrome. I feel that I have many people around me that do have it, but I don't quite grasp it. So that's gonna be an interesting topic.
Yeah, I agree. IBS is very interesting, and I think it's one of those diagnoses that people get when we can't find another cause for the constipation or the diarrhea. So it's kind of a lot like the PCOS that we talked about in women's health, is that like, well, it's not Crohn's disease, it's not ulcerative colitis. I guess we'll just call it IBS. So I think a lot of people are diagnosed with it because we can't find an etiology for that. Anybody else want to share what they're looking forward to learning about?
I'd like to learn more about the drug-induced GI disorders. I think it's a very common complaint, say, oh, this medication made my stomach upset, but like we'll get more into the weeds and details about like more severe side effects and like some like, I guess, complications from medication, stuff like that.
Okay. Yeah, great. Medications are always the first to be blamed when something goes wrong with a patient. So understanding how to evaluate whether it might actually be a medication or it might be something else is really critical for us as pharmacists. So great.
Yeah, I agree. Like with Jadiel, for me was all seem very interesting, but like the drug induced GI disorders for me is like the most excited about.
Okay, great. Thank you for sharing. Y'all are quiet today, even in the chat. There's like nothing going on. Are you frozen?
A little bit.
Especially those from warmer climates, hey? All right. So we're going to start with talking about pancreatitis today. Okay. And so when we think about the pancreas, most of us, our brains generally jump to insulin and the pancreas secreting insulin to help us use the sugar from the candy and the donuts and the ice cream that we eat. But there's much more that the pancreas does besides just insulin and digestion and use of sugar. All right. And so we're going to explore the pancreas today. So these are the objectives today. These are background knowledge, like it's part of the story so that you understand what's going on. So describe normal pancreatic, endocrine, and exocrine physiological functions, explain the pathophysiological processes leading to the development of pancreatitis. The areas I want you to focus on for studying are here. So identify potential risk factors for the development of acute and chronic pancreatitis. Identify signs, symptoms, and laboratory parameters consistent with diagnosis of acute or chronic pancreatitis. Design a treatment plan for the management of acute and chronic pancreatitis, and develop monitoring plan for the management of pancreatitis, including safety and efficacy. All right, so we have the pancreas here, and the pancreas lies on the posterior abdominal wall behind the stomach. We have the head of the pancreas, which is right here, and that connects to the duodenum here. So it dumps into the duodenum here with the sphincter of Oddi. All right, and then there is a duct that runs from the sphincter of Oddi to the tail of the pancreas. And here we, at the sphincter of Oddi, not only do we have the pancreas, this duct running into the duodenum, but we also have the common bile duct from the liver coming in here, and the gallbladder also draining into here to release enzymes from the gallbladder, so bile from the gallbladder and enzymes from the pancreas into the duodenum, so we can use the nutrients from our food. All right. This sphincter of Oddi is a sphincter, much like the sphincter in our esophagus that we talked about, the lower esophageal sphincter that we talked about in self-care with GERD. And so that sphincter opens up to allow the bile and the pancreatic enzymes to flow through, and then it closes so that those pancreatic enzymes and bile cannot flow back in here. So those pancreatic enzymes are activated in the duodenum, and if they are allowed to flow back into the pancreas, that's bad news bears, because if they're activated, they're going to start digesting the pancreas. All right, so that sphincter of Oddi is really important, and keeping that sphincter of Oddi tight and only opening when it should to allow stuff out and not opening and allowing stuff back in as reflex is really important to maintaining the health of the pancreas. All right. So for pancreatic function, we know, I think most of us are familiar that the pancreas is related to endocrine function. So that our pancreas helps with insulin, producing insulin, releasing insulin. When we have sugar that we need to use, it's responsible for glucagon, which is helpful when we don't have enough sugar in our body and we need a burst of sugar from either our muscles or fat. And then also it's also responsible for somatostatin. All right. So all of these are mostly related to blood sugar control and, or lack thereof for people who have diabetes. Right. But we're not going to be focusing on this portion because that'll be in the fall for you. We're going to be focusing on the exocrine function, which is the pancreatic juice. All right. When a patient has pancreatitis, it is generally an issue with the exocrine function. and that's the stuff that forms the pancreatic juice. Pancreatic juice is water, electrolytes, pancreatic enzymes, bicarbonate, and all of these help with digestion of food, especially fatty acids, peptides, and glucose in the duodenum. The pancreatic juice is secreted and triggered the production, and the secretion is triggered by the sight, the smell, and the taste of food. These enzymes, again, are not activated until they are dumped into the duodenum here. So they have to be dumped into the duodenum to be activated in a basic environment. All right. We want them activated in the duodenum because that's where the nutrients are. And so it makes sense that we would want those enzymes to be activated in the duodenum where the nutrients are, so they can start breaking down the nutrients, and where they can be absorbed in the small intestines, because that's where we get most of the absorption of our nutrients. We don't want them breaking down in the stomach because we don't really absorb a lot from our stomach. We absorb most of our nutrients from our small intestines. There are different type of pancreatic enzymes for each nutrient that we ingest. So we have amylase, which is responsible for breaking down starches and glycogen, so sugars. We have lipase, which is responsible for breaking down triglycerides and cholesterol or fats. We have trypsinogens and chymotrypsinogens, which are responsible for the breakdown of proteins. And then we have nucleases, ribonuclease and deoxyribonuclease, which are responsible for breaking down nucleic acids. I've highlighted amylase and lipase because these are going to come into play when we're talking about diagnosing and evaluating for pancreatitis. So you'll see those again. So if you recall, I said that enzymes need a higher pH to be activated. And so again, they're dumped into the duodenum, which has a higher pH, which is more basic, so that they can be activated. Here, the proteolytic enzymes like the trypsin are secreted in the inactive zymogens into the pancreas, so the trypsins come into the pancreas and they are inactive zymogens so that they don't digest the pancreas because that will be painful. And so then it becomes part of the pancreatic juice. And then that pancreatic juice contains the trypsin inhibitor to inactivate that trypsin to make sure that it doesn't become activated inside of the pancreas. Once that pancreatic juice is dumped into the duodenum, enterokinase activates those zymogens, and those proteolytic enzymes become active so they can start breaking down the food and the proteins that you ate. But you're wondering, I said that there was a trypsin inhibitor in that mix. Once that trypsin inhibitor is dumped into the duodenum, the concentration is so low that it's not effective. So the trypsin inhibitor goes all over. It's not in constant contact with that zymogen, and so it's not effective anymore. That's what should happen, all right? That's what should happen. But if it always happened like this, we wouldn't have this lecture or anything to talk about today. So when things don't work like they're supposed to, we get pancreatitis, which is a very angry pancreas. All right. So pancreatitis, itis meaning inflammation of the pancreas. It can be acute, which is sudden or sudden onset. So all of a sudden it comes on. It can be of short duration, or it can be chronic, which is a gradual progressive and can lead to organ damage. All right. We're going to go over each of these separately as we move through. Question for y'all. When you are studying a disease, do you tend to get the symptoms? Like if you're studying diabetes, do you all of a sudden like, oh my gosh, I'm peeing all the time. I'm so thirsty. I think I might have diabetes. Or So as a parent now, when my kid says his neck hurts, I'm like, oh my God, he has meningitis. But I learned that little kids don't know the difference between their neck and their throat. So oftentimes when little kids say that their neck hurts, they're talking about their throat and not their actual neck. So did any of you all get like this when you're studying a disease?
I
Become a
think Victoria is this kind. I've heard stories.
What's that?
I don't know if Victoria is in class today, but Victoria.
Yes, I'm here.
You kind of become a hypochondriac and like, oh my gosh, I have all these things. So a little bit more, keep that in mind as we're moving through here, because I teach this. So talking about acute pancreatitis, this is not a kid with acute pancreatitis. This is a kid who wanted more jam on his toast and was told no. But this is how patients feel when they have acute pancreatitis. They're very distressed. They're very upset most of the time. So think about that it's sudden, it comes on, you're acutely in distress because, like this toddler, you can't have more jam on your toast. So acute pancreatitis is something that you're probably going to run into on your APPEs, on your acute care APPEs. It's very common in the hospital, especially in places like downtown Baltimore, any of the major cities that I've worked in hospitals. I see it on a regular basis for patients coming into the hospital. And we are seeing an increase in pancreatitis because of the obesity epidemic. And when patients are obese, that increases their risk of gallstones. And as we'll talk about, gallstones are one of the risk factors for pancreatitis. All right. Mortality is up to 5%. But if a patient presents with organ failure, their mortality jumps to 35%. So it's very important to catch this early and to treat it early. If a patient has an infected pancreatic necrosis, the mortality is 20%. So if this is not caught early and not treated, the mortality risk is very high. So do keep that in mind. Okay, so how does pancreatitis happen? It starts with some kind of assault on the pancreas, some kind of acute injury going on. And then that injury causes that premature activation of trypsinogen. So that substance that digests proteins, or so that the trypsinogen is activated inside the pancreas, and that causes autodigestion of the pancreas, which ouch. All right. When that trypsinogen is eating away at that pancreas, we start getting damage and necrosis of the pancreatic tissue, and that starts an inflammatory response. So we get cytokine release, we get inflammation, which leads to further injury, right? And then that leads to pancreatic edema and necrosis of the pancreas. So your pancreas dies. So risk factors for pancreatitis, you can remember, maybe what you do on the weekends. I get smashed. So it can be idiopathic, which means we don't really know why it's happening, but it's happening. It can be because of gallstones, which like I said, people who are overweight, obese, have an increased risk of gallstones. So we are seeing more gallstones because that gallstone, if we go back to that picture of the pancreas, those gallstones are going to come down and block this sphincter of Oddi here, because the gallstones form in the gallbladder here, and they come down the same similar duct that connects to the Oddi. And so if we're having a gallstone blocking this, those enzymes can't get out, and they start autodigestion. All right. Alcohol is probably the number one cause that I've seen in my career of pancreatitis in the hospital. So people who go binge drinking, people who have alcohol use disorder. Alcohol is one of the top causes of pancreatitis. Trauma, so injury, steroids, mumps or malignancy. So, we might see a resurgence in mumps here as immunization decreases for patients. So do keep that in mind. The MMR vaccine does prevent against mumps. But the uptake of that vaccine has significantly decreased in recent years. Malignancy, so a tumor blocking that sphincter of Oddi, autoimmune, scorpion stings, hypercalcemia and hypertriglyceridemia, ERCP, which is a surgical procedure, and then drugs can cause acute pancreatitis. So the two that I want you to remember as major risk factors for pancreatitis are gallstones and alcohol. All right, so please make sure that you know that those are common risk factors for pancreatitis. So I'm going to say it again, that gallstones and alcohol cause about 70 to 80% of pancreatitis cases. So really important that you recognize those as risk factors. Gallstones, again, block that sphincter of Oddi, backing those pancreatic juices into the pancreas. A pancreatic tumor can also do the same. So those would be a structural risk factor. Alcohol is a toxin, right? We can have infectious, which are bacterial, viral, parasites. Metabolic is going to be hypertriglyceridemia and hypercalcemia because that has to do with our metabolic state. Genetic factors like cystic fibrosis, alpha-1 antitrypsin deficiency, and hereditary can cause pancreatitis. Medications, we're going to talk about that more, and you're going to investigate that more tonight as homework. Trauma or surgery, and then vasculitis, atherosclerosis, cholesterol emboli can all increase the risk of pancreatitis. Note on the hypertriglyceridemia, it is triglycerides greater than 1,000 that increase our risk of pancreatitis. So our normal triglycerides are like less than 150, but you can have high triglycerides and not have a problem. It's when those triglycerides get over 1,000 that you're at increased risk of pancreatitis. So special note of that. So this is why it's important to take a thorough history of patients who have pancreatitis to figure out what's going on. Do you have a history of gallstones? What is your alcohol intake? How much do you drink? And not, letting the patient off, oh, I only have 1 to 2 drinks. Well, what do those 1 to 2 drinks look like? Is it a tall boy? Is it a mixed drink that you made yourself? Do you consider 1 bottle of wine 1 drink? We really have to quantify how much people are drinking to truly understand the alcohol risk. So we need to be very specific about our questioning. All right. Have you had trauma? Have you had an accident or have you fell? Sometimes we can have an accident that we don't feel like we had any trauma, like a car accident or whatever. And there was actually internal trauma that happened that we weren't really aware of right away. Do you have a family history? Right, so really important to get a thorough history. If we're thinking about medications, we want to know when you started medications, when you stopped medications, how long you've been taking medications, because there's going to be a lot of factors that we need to know related to the medications to determine if it's medication induced or an adverse drug reaction. All right, so how do these patients look when they show up at the hospital for acute pancreatitis? They look like the little boy who couldn't get more jam on his toast. They are in acute distress. Most patients will complain of epigastric pain, about 95% of patients, and this is because there's increased pressure in the pancreas. A gallstone can cause sudden and severe knife-like Alcohol is more insidious, so it's more creepy, like the pain kind of creeps in and is kind of all over. It's not in one particular spot. All right. We will see patients have nausea and vomiting, about 85% of those patients. And this is typically they're like after they've eaten something that they get really nauseous and maybe start vomiting. If we have severe nausea and vomiting, that can lead to dehydration, which then leads to the organ damage because dry kidneys aren't happy kidneys, right? If you're dehydrated, you can't, if you're dehydrated, you have less blood flowing, which is carrying less oxygen, which is making everything less happy. So, dry kidneys aren't happy kidneys because they're not getting the oxygen that they need to work properly. Okay. Most cases are self-limiting and resolve on their own, but sometimes patients can end up leading to SIRS. You guys all learned about SIRS last semester with sepsis. Yes, no? Okay. Right. Patients will have tenderness on palpation of the abdomen plus rebound tenderness. So rebound tenderness means you're like trying to stop them from touching you in your abdomen area. Right. Again, like I said, most cases are self-limiting and resolve within 48 hours. But if you have extreme dehydration, that's going to lead to organ damage and organ necrosis. 20 to 30% of patients present with SIRS, which is a key determinant of mortality. And necrosis increases the risk of organ failure. So what I want you to remember from this list is that patients present with pain and nausea and vomiting. All right, so last semester and probably for a couple months before, every time I ate dinner, I just didn't feel very good. And I'm like, well, this is weird because I can drink my like protein breakfast fine and have no issues. But every time I ate dinner, I just felt a little sick. And I'm like, this is a little bit weird. If it wasn't happening with just dinner, I would think I'd have like some kind of low-level pancreatitis, but whatever. I'm just going to ignore it because getting healthcare is hard, even when you have insurance. Like getting to see your primary care, it's not bothering me that much. So in November, I took a day off to while my kid and husband were at school so that I could have a like self-care day and do whatever I needed to do. And I scheduled a day at the spa and I get a facial and then I get a pedicure and then I feel like I'm really hungry at this point. And I hadn't ate for like 3 hours and I was waiting for my massage. So I grabbed some like trail mix that was in the relaxation room waiting for my massage and I ate them and I felt worse than I did before I ate them. And I'm like, well, this is weird. Maybe this trail mix is too much protein and I don't have enough carbs. Maybe my blood sugar is low. I don't know what's going on. So I have the massage and things are just like not going very well and get through that. And I was like, okay, well, I'm going to take myself out to lunch. I'm over by this great Italian restaurant that I don't get to go to very often because everything is really spread out here in Colorado Springs, and take myself out to eat. And I start eating the food and I start getting really sick, like very nauseous. I eat the bread, I eat the pasta, and I'm getting really nauseous and I'm getting hot and feverish. And then I'm freezing cold. And then I feel like I'm going to throw up. And I'm like, well, it wasn't because my blood sugar is low. I was like, if I didn't know any better, I would think I have pancreatitis because here I am eating this food and I'm getting sick. And I have this really bad abdominal pain. I'm like, but then I go through, I'm like, I don't have any risk factors. I don't drink as much alcohol as I used to. Like I barely drink anymore because if you're hungover or drinking, it makes it hard to be a good parent and be patient with your kid, at least for me. So I just like, I don't want to do that. So alcohol is not a risk factor. I don't think I have gallstones. I've never had gallstones before. I don't really know what's going on. I have no other risk factors. So it's not pancreatitis. It can't be pancreatitis. So I decided to go to the urgent care to get some Zofran or whatever because I was feeling that bad. By the time I get to the urgent care, I'm feeling better, like close to the urgent care, I'm feeling better. And I'm like, oh, I should just go home. And they're like, no, because if I get sick at home, that's another 20-minute drive to the urgent care and waiting. So I just go to the urgent care. And the provider comes in and sees me and she asks me questions. I tell her all of this and she goes, well, you're of the right age. You're between 30 and 50, female. You probably have gallstones. And I'm like, whatever. No, I don't. She pushes on my stomach and I have a positive Murphy sign. So she pushed on my abdomen and I about jumped off that table at her. She's like, you need to go to the ER right away. Because I think it's your gallbladder. I can't do anything about it. So finishing the story, I did not have pancreatitis. I had gallstones, and I had a necrotic gallbladder that had to come out. But this is where my brain like automatically went when I had these symptoms because I was preparing to teach this, or I have taught this. This is my like 6th year teaching this. So like I'm pretty sure I have pancreatitis, but nope. So I went through all the checklist of all the things we just talked about. So sometimes knowing this information is good to help you. So now I have great stories to talk about how the gallstones cause pain and what a positive Murphy sign is and what the best medicines for nausea and vomiting are. So when they, check my labs, they're looking for, or anybody's labs who have pancreatitis, you will see an elevated amylase. Amylase is not very helpful for pancreatitis because it peaks within 24 hours and then it returns to normal within the next 3 to 5 days. It's also non-specific because it's also secreted by salivary glands, kidneys, hepatobiliary, and metabolic disease. So it's not specific to the pancreas, but we can see it elevated in pancreatitis. Elevated lipase is what we're really looking for to determine if it's pancreatitis. My lipase was normal, so definitely, probably not pancreatitis. The lipase remains elevated while the pancreas is inflamed throughout and doesn't go back down, and it has a longer half-life than amylase, so it's going to stay higher longer. So lipase is more specific to pancreatitis. If we start seeing necrosis or we have infection, we can see an infected or elevated white blood cell count. We can see liver enzymes be elevated, especially with gallstone pancreatitis or intrinsic liver disease. So we can see an elevated AST, ALT, alkalis, and bili. Which you should remember when we talked about cirrhosis, that these are increased in patients with cirrhosis. So don't forget all that liver stuff because there's a little bit of liver carryover here. So to diagnose pancreatitis, we need 2 out of the 3. We need an upper abdominal, we need the patient to have upper abdominal pain. We need to have them have serum amylase or lipase greater than 3 times the upper limit of normal. And then imaging. So we need 2 out of 3 to diagnose pancreatitis. Please know the diagnostic criteria for pancreatitis. Normally, because imaging like ultrasound or CT scan can take a while to get. So most of the time we're diagnosing people based on their upper abdominal pain and their lipase. So at the emergency room, which was like the wild, wild west, they confiscated my nail clippers from my purse before I went through these security or the metal detector. But anyways, that was an experience. They did an ultrasound. And so when they're doing the ultrasound, they're not just looking at the imaging of the gallbladder and the pancreas. They're also looking at how you react because they're pushing on your belly, your abdomen, right where you should be having a reaction. All right. And so because I hadn't ate anything and the pain had subsided, I wasn't having a reaction and there was nothing showing up on my ultrasound except some wall thickening. They're like, oh, she's fine. So then they had to send me for a CAT scan, which showed that my gallbladder was necrotic. But it took a long time to get the ultrasound and a long time, and then an even longer time to get the CT scan. So imaging is usually not required and not done because it takes too long to get. So again, that imaging is an abdominal ultrasound looking for enlargement of the pancreas, fluid collection, gallstones, and then the CT scan. We generally only get a CT scan if the patient is failing to improve. That helps to see the pancreas a little bit more clearly, to see if it's interstitial versus necrotizing. The CT scan is best 72 hours. This is all like nice to know information. So goals of therapy, we want to correct the contributing factors. So we want to remove the offending drug. We want to have glucose control. We want to have triglyceride control. And if SIRS is present, we want to treat them like they have sepsis to help prevent organ failure and mortality. We want to relieve the pain and nausea. That's what the patients care about the most, right? That's what brought them in. So we want to relieve the pain and nausea. So we're going to have to use IV medications because they're sick and throwing up. So they're not going to be able to keep them down. So we want these medications to be IV. We want to replace the fluids because these patients can be dehydrated, especially if they're not eating and they're throwing up. So we need to make sure that they're adequately hydrated so their organs are not getting dried out and dying. When we give fluids, we have to be mindful that can throw their blood sugar and their electrolytes out of whack. So we want to make sure that we're monitoring that to make sure that we're not causing any further problems. And all of this leads to preventing organ failure, pancreatic necrosis, and infection. We're using the IV fluid resuscitation. Nutrition, we used to think back when I was in your shoes that we should not let these patients eat. That is not the case anymore. As soon as their nausea and vomiting has subsided, they should start eating right away. And so making sure that they're getting on a diet as soon as possible because that decreases length of hospital stay is if they're eating sooner than later. We only give antibiotics if we suspect an infection or we know that they have an infection. And then if there's necrotizing, there might need to be surgery, but that's beyond the scope of us. So please, make sure you're paying attention to everything that's drug related up here as far as treatment. So sometimes in the surgical debridement, we have to clean out the pancreas. Other times we have to clean out the pancreas and make sure we're removing the gallbladder because then those gallstones, the gallbladder will continue to form gallstones and drop them in to go through that and get stuck in that sphincter of Oddi, which can increase the risk of pancreatitis. All right, so how does fluid loss happen? We have the nausea and vomiting. So we're nauseated, we're not taking in enough fluid, we're vomiting, we're throwing up everything we drink, but there's another process to this fluid loss and why it's so serious in pancreatitis. This is nice to know. And I'm telling you this so you understand that dehydration is one of the biggest risks related to pancreatitis because it doesn't just come from not being able to eat and drink and from throwing up. When you get inflammation, which is what happens when your pancreas starts auto-digesting, you get vasodilation. When you get vasodilation, you get capillary leakage. We talked about this with portal hypertension, splenic vasodilation in the abdomen area, which led to leakage of fluid into the abdominal cavity, which led to which disease state?
Varices?
That's due to the increased pressure. Varices are due to the increased pressure along with the increased fluid.
Ascites?
Ascites, yeah. So all that fluid leaking out of the blood vessels into the abdominal cavity led to ascites. So we get the same thing happening here. We have inflammation, we have vasodilation leading to that capillary leakage, which leads to intravascular fluid loss. So that fluid is leaving the blood. We're getting hypovolemia, so low blood volume. We don't have enough blood pumping around, so we get decreased perfusion to our organs because we don't have enough blood. Decreased perfusion means decreased oxygen to our organs, leads to organ death. All right, so there's two ways that we have this fluid loss going on: the nausea, vomiting, not being able to drink anything, and then this inflammation from the autodigestion leading to this process that also depletes our intravascular volume. So that being said, fluid resuscitation is the cornerstone of treatment, all right, for pancreatitis. This by doing fluid resuscitation, we ensure that we're getting that intravascular volume up and that we're adequately perfusing the organ tissue. It's associated with decreased rates of SIRS. So we're going to prevent SIRS if the patient does not have it. We're going to prevent organ failure. And the first 12 to 24 hours are the most important to prevent organ damage. So fluid resuscitation decreases mortality of patients with pancreatitis. It is the most important treatment that we're going to talk about today. So when we're talking about fluid resuscitations, we have crystalloids and colloids. Crystalloids are preferred over colloids. Crystalloids are things like normal saline, D5W, you know, that shoe store. Oh, that's DSW, sorry. And then lactated ringers. Lactated ringers, most of the time when we talk about crystalloids, we don't really care. We pick the best one for the patient based on what they have going on. If their sugar is low or not high enough, or if their sugar is too high, we might pick normal saline. But for pancreatitis, we're going to pick lactated ringers. All right. This has been shown to be better than normal saline and dextrose to reduce the incidence of SIRS compared to normal saline. So lactated ringers is the preferred crystalloid for pancreatitis fluid resuscitation. Right. This is going to help increase the circulatory volume, which is going to help perfusion of the organs and to help prevent organ death. Yes, Jose Yvonne. Oh, you're on mute still.
Could you refresh me on what a crystalloid is?
So a crystalloid is are fluids that expand total extracellular volume. All right. And so crystalloids are fluids that are very close to are the fluids in our body. So like normal saline is isotonic, which means it has the same tonicity of our blood. Like dextrose 5, again, has a similar tonicity to our blood. So along with lactated ringers. So they are more for a dehydration kind of picture and making sure that our fluid status is appropriate compared to our colloids. Colloids are things like albumin, hetastarch, dextran. Those are stay in the intravascular space. They don't leave the intravascular space. Albumin has a very short half-life, so it's not going to work for a very long time. They have high risk of anaphylaxis and they're expensive. Colloids are more kind of protein based. And so where crystalloids are more kind of like a water solution based.
Thank you.
Yep. We want to make sure that we're watching the patient closely while we're giving them the fluids because we don't want to give them too many fluids. Because if we give them too many fluids, they can have compartment syndrome where the fluid is all in their extravascular space, making it difficult to walk. It can cause pulmonary edema, which is fluid on the lungs, making it difficult to breathe. So ways that we monitor for efficacy are going to be monitoring the heart rate to make sure that because as you get dehydrated, So as your fluid status goes down, your heart rate goes up because your heart rate is compensating, trying to perfuse, trying to get oxygen to everywhere it needs. So we're going to monitor the heart rate to make sure that the heart rate is coming down and not staying up too high. We can monitor the mean arterial pressure. That gets a little bit difficult to measure. We're going to monitor urine output, make sure that their kidneys are still working. Hematocrit also tells us hydration status. That's a lab value. And then respiratory status to make sure that they're not getting pulmonary edema. So we're going to start lactated ringers, and we're going to monitor these for efficacy and safety of our lactated ringers. For symptom management, we have nausea. We are going to use, you notice we're going to start with IV antiemetics, ondansetron, prochlorperazine. We're going to talk more about the different choices next week, so don't get hung up on the choices. But the thing I want you to remember is that they're IV because the patient is vomiting. If we give somebody something oral, they're going to throw that up, and that's not going to be helpful. So we need IV antiemetics. For pain, we're going to use IV opioid analgesics. If it's very severe, we might consider a PCA, patient-controlled analgesic. All right, but with IV opioids, okay. Once the patient's nausea and vomiting is controlled, we switch to PO as soon as possible. But we start with IV and we switch to PO as soon as possible. And that's one of the biggest things that we can do as pharmacists. When I hear that my patient is eating or drinking, I'm like, okay, let's change all these medicines to oral. And because the other people are thinking and focusing on different things, this is not only a cost-saving measure for the institution, but as soon as we can get patients PO, the sooner they can go home. So this is a really impactful thing that pharmacists do.
And how much is the difference? Like, is it like very dramatic, like in terms of cost?
So when you think about the administration time from like a nurse giving something IV versus a nurse giving something PO, so you have the administration time, you have the product. The oral products are generally low cost, high value compared to the IV products. So when you take all those things into consideration, but the biggest thing is that as soon as they're on PO, they can go home, and if they can go home sooner, that's the biggest cost savings there is getting them out of the hospital as soon as possible. Because not only does it decrease their cost of their stay, but it decreases their risk of getting any other infection or any other complications that would cause them to stay longer or come back. So it's a whole conglomerate of things that decrease the cost of being PO. All right. So when I was a student, we said our patients could not eat until their pancreatitis was completely cleared. But things have changed a lot in the last 20 years. We thought that feeding them would stimulate those pancreatic enzymes and cause more pain and make things worse. Since then, we've discovered that feeding them sooner decreases the length of stay and decreases the risk of necrosis and organ failure. So once they're able to tolerate foods, and their nausea and vomiting is controlled, we're going to start eating them, or start letting them not eating them. Oh my gosh. We're going to start letting them eat as soon as possible. Okay, the patient doesn't need to be pain-free to start eating, but they do need to be not vomiting to start eating. We're going to start them eating as soon as possible. There's no like length that they have to be NPO. There's no length that they have to be liquids only, clear liquids only. As soon as they're not throwing up and they're able to tolerate it, we will start them eating. So, please know that nutrition, we're going to start it as soon as possible. We want them to be taking it by mouth as soon as possible because it decreases length of stay, decreases necrosis, and decreases organ failure. Patients can have infected necrosis of the pancreas, but we do not recommend prophylactic antibiotics unless the patient has indications of infection. So prophylactic antibiotics are not recommended for people who have pancreatitis, only if they have an infection. Also, if they are failing to get better after 7 to 10 days, that's when we would consider adding on antibiotics. We need to get a culture with a CT guided aspiration. If the culture is negative, that means there's no infection, so no antibiotic. Empiric antibiotics should, if the patient's not getting better in 7 to 10 days and they do need antibiotics, we want our antibiotics to cover aerobic and anaerobic organisms for 2 to 3 weeks. So that would be carbapenems. If you think about carbapenems, they have very broad coverage, if you remember. So if I think about my antibiotic or my bugs like this, so over here I have gram-positive bugs, over here I have gram-negative bugs, up here I have aerobes, and down here I have anaerobes. Sorry, my writing is terrible. And when I think about carbapenem coverage, carbapenems are going to cover gram-positive aerobes, gram-positive anaerobes, gram-positive or gram-negative anaerobes, and gram-negative bugs, right? So carbapenems are very broad coverage. When I think about, oops. Fluoroquinolones plus metronidazole. Metronidazole covers gram-positive and gram-negative anaerobes, and fluoroquinolones cover gram-positive, a little bit of gram-positive aerobes, and a lot of gram-negative aerobes. So that's why we're picking carbapenems and ciprofloxacin or levofloxacin plus metronidazole, because we have a broad range of coverage, right? So to the right of the y-axis is gram-positive bugs. To the left of the y-axis is gram-negative bugs. Top of the x-axis is aerobes, because aerobes need oxygen. They live above ground. That's how I remember it. Anaerobes don't need oxygen, so they live below ground. Out here are the tough to kill bugs. So that is like Pseudomonas, Acinetobacter, or space bugs. And over here are our tough to kill bugs like VRE, vancomycin resistant, MRSA. Anaerobes, I don't really think about knowing all the names of them, because B. fragilis and C. diff are the ones that are most common. Right. We will break right here. We'll take a 5-minute break. So come back at 12:30 to finish the lecture.
Dr. Hall,
Yes.
um, how do you know that the tissue is necrotic? Is it through a CT scan or how?
So I'm not sure if it would show up on an ultrasound, but it would definitely show up on a CT scan.
Hmm.
And it has to do with like the measurements of the like I'm not 100% sure about the pancreas, but because of I had a necrotic gallbladder, it has to do with they measured like the thickness of the wall of the gallbladder, and like how big it was. And because it was like not it was smaller than it was supposed to be, and the wall thickening was very thick, that's how they determined it was necrotic on the CT scan, was by the measurements that because they didn't align with what it should have been. So I would imagine it would be very similar for the pancreas.
You said the thickening was for the gallbladder, but you think that should be more or less the same for the pancreas.
So that's how they determined that on the CT scan that my gallbladder was necrosed. I would assume that it's similar for other organs as well.
Hmm.
But I'm not an expert on all of that. All right. We are going to move on to chronic pancreatitis now. So changing speeds a little bit. So chronic pancreatitis is a progressive disorder of the pancreas, and it's from continuous or episodic inflammation that results in the destruction of pancreatic secretory cells, leading to progressive failure of the exocrine and endocrine functions of the pancreas. So chronic pancreatitis is progressive and it's not reversible. We're not really sure how this happens. We think that it could be oxidative stress from toxins. We think that it could be obstruction leading to inflammation. We think that it could be repeated episodes of acute pancreatitis leading to necrosis and fibrosis. There's a lot of theories on how chronic pancreatitis happens. But some way or shape or form, we are getting chronic inflammation in the pancreas. and that chronic inflammation is leading to irreversible destruction of pancreatic tissue. We start getting fibrin deposition in the pancreas. So fibrin is stiff, making the pancreas not flexible, not able to function. And we get that loss of pancreatic function. Remember that the pancreas has two functions. It has endocrine, which are our insulin, our glucagon, our blood sugar control, and exocrine, our digestion. All right. So stages of chronic pancreatitis are, at first, we don't really, there's like non-specific. We have some abdominal pain, maybe discomfort, really non-specific, not really sure. Then we will start seeing acute attacks of pancreatitis. So things start to escalate. And then we'll start to see episodes of intermittent or constant abdominal pain. So we'll have really, strong pains. It'll be intermittent or it can be constant. And so again, but as we're seeing, it's starting out, but relatively benign, but over time becomes more persistent and more severe, and we hit the burnout stage here. In the burnout stage, we really don't have any more pain going on, but we have malabsorption syndrome. So we have the loss of exocrine function. So you might see diarrhea, you might see weight loss because you're not absorbing nutrients. You might see decrease in various vitamins, like your fat soluble vitamins, ADAC, ADE, and K. Because you're not able to absorb them because you're not putting out that pancreatic juice with those enzymes to absorb those nutrients in the duodenum. And then you will also see diabetes, which is the loss of the endocrine function. Usually malabsorption happens in about 5 years from diagnosis of chronic pancreatitis, and diabetes happens about 3 years after that. So about 8 years after diagnosis of chronic pancreatitis. If we have chronic pancreatitis, that increases our risk of pancreatic cancer. So know that, in late stages of chronic pancreatitis that you have malabsorption syndrome from loss of exocrine function and diabetes from loss of endocrine function. We see similar risk factors for chronic pancreatitis here. We have Tiger O, toxic metabolic. We see chronic alcohol use again here. Nicotine, hyperlipidemia, hypercalcemia, medications, idiopathic, we don't really know. Genetic mutations, a lot of patients with cystic fibrosis have chronic pancreatitis or alpha-1 antitrypsin deficiency. You can have autoimmune, recurrent acute pancreatitis, or an obstruction. We're finding that idiopathic is more common than we previously thought. Medications are most commonly associated with acute pancreatitis, though. So clinical presentation of somebody with chronic pancreatitis, they have abdominal pain in their epigastric area. So epigastric is right where their esophagus meets their stomach. Nausea, vomiting, steatorrhea, which is fatty diarrhea. So you have loose, oily stools or diarrhea. Fat, weight loss, fat soluble vitamin deficiency. So that's our ADAC, ADE, and K. There's actually a vitamin called ADAC. That's how I remember that ADE and K are fat soluble vitamins. Jaundice if we're obstructing that biliary flow. So pain is going to be first and diabetes is going to be last. Laboratory findings, we're going to see amylase and lipase are only elevated in acute exacerbations. They're generally within normal limits for chronic pancreatitis. Fasting blood sugar may be elevated. So you might see some endocrine dysfunction, but again, that's stage 4. Diabetes is last. The diagnosis is based on signs and symptoms. We can also get imaging like ultrasound, CT, MRI, but it can take years for chronic pancreatitis to show up on imaging. Our treatment is to have pain relief for the patient, treat the malabsorption so that they are getting those fat-soluble vitamins. If they have diabetes, treating diabetes and improving the quality of life. Our non-farm treatment is lifestyle and diet, so small, frequent meals, low-fat diets. We can also do surgery or invasive procedures if there's no other effective treatment. That's not going to be our call. For pharmacological management, we're going to do pain management, and then we're going to talk about pancreatic enzyme supplementation. If they develop diabetes, we're going to do insulin. Luckily for you, we are not going to talk about diabetes management in this course. I'm going to save that for Dr. Foles to tell you all about next year. We are going to focus on the pancreatic enzyme supplementation. All right. So again, non-farm, we're going to try and abstain from alcohol and smoking because those can make things worse. If the patient has experienced steatorrhea, we're going to have small, frequent meals. We're going to try to eat low-fat meals. All right, so I want you to remember these as non-farm treatments. If they're still having weight loss, despite small, frequent meals and enzymes, they're going to need a feeding tube. That's not our call as pharmacists. And then there's surgical procedures that can be done as well. Again, not our call as pharmacists. So focus on the things that we can help with. We can help with alcohol, abstaining from alcohol and smoking. We can help with counseling on small, frequent meals and low-fat meals. For the pain, the pain can be chronic and it can be continuous with exacerbations. There's a lot of reasons that we think that the pain is going on. The pain shows up before there's any visible signs in the structure that's going on. So, when people say they're in pain, we should generally try to believe them because the imaging is not going to show that they have structural damage right away. Pain is the number one reason for medical costs in this disease state and the number one cause for reduction in quality of life. We want to make sure that we're evaluating the baseline levels, classifying whether it's sharp, dull, where it's located, the severity on a scale of 1 to 10, and we want to make sure that we're clearly documenting that. And then we need to establish realistic goals with patients. Like, you are not going to be pain-free with this disease, but if I can take you from a 7 to a 5, that is a significant decrease. If I can take you from a 8 to a 6, that's a significant decrease. A 2-point drop in pain is a clinically significant decrease, but we're never going to get you to 0. And so we do have to manage patients' expectations with their pain. So pain management, pancreatic enzyme supplementation, there's conflicting recommendations on whether it can actually help with pain. Proton pump inhibitors can be helpful, especially if patients are at high risk for peptic ulcer. Non-opioid analgesics, we want to stick with acetaminophen. We want to avoid NSAIDs because of the possible GI side effects related to them. So we want to try to stick with acetaminophen. Tramadol may have similar pain relief and fewer side effects than morphine, but we don't want to use it in patients who are actively drinking because tramadol lowers your seizure threshold, alcohol lowers your seizure threshold. That is very dangerous. Then we can go to opioids. We can use adjunctives like antidepressants, gabapentin, and pregabalin. So for malabsorption, we're going to suspect this if patients have diarrhea, steatorrhea, if they have weight loss, if they're having vitamin deficiency, if they're having bone disease, because vitamin D is a fat-soluble vitamin. So if you're not absorbing vitamin D, you're not absorbing calcium, can lead to osteoporosis, can lead to fractures. So we want to try and treat steatorrhea with dietary modifications, so small, frequent meals, and then pancreatic enzyme supplementation. So pancreatic enzyme supplementation treats malabsorption. That's why we're using pancreatic enzyme supplementation, is for the malabsorption. Right, so indications for pancreatic enzyme supplementation, they have steatorrhea, which indicates malabsorption. They have signs of malnutrition. They have weight loss. They have severe bloating and flatulence. They have abdominal pain with dyspepsia. They're low in those fat-soluble vitamins, ADAC, prealbumin, and magnesium. So again, pancreatic enzyme supplementation is for malabsorption. So what's in these pancreatic enzymes? Pancreatic enzymes are amylase, lipase, and protease. So amylase to help digest our sugars, lipase to help digest our fats, protease to help digest our proteins, right? We learned about that at the beginning. So we basically put those enzymes in a capsule and call it pancreolipase. These enzymes, we're giving it in a pill form, and because they are destroyed by acid, they need to make it through the stomach to be activated in the duodenum. And so we will see things like enteric-coated. We will see things like enteric-coated beads or microspheres. We'll see bicarbonate buffered enteric microspheres. The microspheres are the preparation of choice because they're enteric-coated, so that means that they're not going to break down. They're going to be protected in the stomach, and that enteric coating is going to be removed by the higher pH of the duodenum, and so that the enzymes are going to be able to be activated in the duodenum where they need to be working on the food that we're eating, right? Pancreatic enzyme products, we want this is an important slide, so we want to adjust the dose. We're going to adjust it every 3 days based on their stools. There's a lot of monitoring stools in this module, y'all, right? We monitored stools for which drug on our last exam?
Lactulose.
Lactulose, yes. I saw you mouth it, Jess. Both of the Jesse and Jessica. I both saw you say it. So pancreatic enzymes are another one that we're going to monitor stools and make sure that they're normalized. So instead of 3 bowel movements per day, in this case, we want the stools to become more formed. We don't want them to be diarrhea. So we're going to make sure that the stools are more formed. And weight gain. These have to be taken 3 to 4 times a day, every time you eat, every meal, every snack that you eat, because otherwise you're not going to get the nutrients from them. So these have to be administered with every meal and snack. All right. Otherwise you're not going to get the nutrients from that. So these are 3 to 4 times a day medications. A H2 blocker or PPI can increase the effectiveness because it's going to increase the pH of the stomach and decrease the risk of that drug being broken down in the stomach and make sure that it gets to the duodenum. And it also helps with lower doses. Patients may still require a fat-soluble vitamin with these enzymes. The side effects are nausea, diarrhea, abdominal pain, flatulence, but is that a side effect of the disease or the drug? That can be kind of hard to tease out. We can get colonic strictures, mucosal irritation, and they might precipitate gout. All right, so when you're thinking about acute, summarize everything we just talked about. When you're thinking about acute pancreatitis, it's sudden onset, short duration. It's caused by alcohol and gallstones mostly. It's diagnosed on 2 of the 3: pain, increase in lipase 3 times the upper limit of normal, or imaging. So 2 of the 3 of these. Symptoms include pain, nausea, and vomiting. Our treatment is lactated ringers, right? To prevent dehydration, prevent organ damage, make sure our organs are still being perfused. IV antiemetics and IV opioids to start with. To make sure that they're getting enough fluids to prevent the morbidity from their organ damage. We're going to monitor their heart rate to make sure that's coming down, their mean arterial pressure, make sure that they're making enough urine, their hematocrit to make sure they're not dehydrated, and their respiratory status to make sure they're not getting fluid overloaded. Does anybody need to take a screenshot of this before we move on?
I had a question on 1, 2, 3, 4, 5, 6, 7, 7 slides back. Sorry, maybe I should wait till the end. I was thinking maybe to bring some allowing people to take the screenshot. But there was a CI in patients in tramadol. I wanted to know what the abbreviation was for CI in patients with alcohol use.
CI is contraindication, so it cannot be used.
Contraindication. Okay, thank you.
Yep. Right. So to summarize, chronic pancreatitis, it's gradual, progressive, and leads to organ damage. One of the top causes is alcohol. We do see other things like genetics, but the top cause is alcohol. Although you'll see a lot of these medications in cystic fibrosis patients. Complications for stage 4 are malabsorption and then diabetes. So pain is first, diabetes is last. Malabsorption comes right before diabetes. Patients can have abdominal pain, they can have nausea and vomiting, they can have diarrhea, steatorrhea, and weight loss. The treatment of this, I want you to focus on pancreatic enzymes. All right. And then monitoring, we're going to monitor their pain, nausea and vomiting, stools, weight, and blood sugar. Okay.
Dr. Hall,
Yes.
can you go to the previous slide? I'm sorry.
I will put it up at the end of class because I want to make sure that we get through this next section to make sure that you have the information you need to do your homework tonight.
Okay, thank you.
Yep. All right, so another shot of Pikes Peak from my house. We're going to move into drug-induced GI disorders. I was supposed to have an Appy student with me today, but he is sick, so you're stuck with me today doing this all. So learning objectives are there for your review. All right. We're going to talk about drug-induced GI disorders overall, and then we're going to talk about drug-induced liver injury and drug-induced pancreatitis. So drug-induced GI disorders are an injury induced by a drug or an herbal medication leading to laboratory abnormalities and or organ dysfunction, where we have excluded all other possible causes. So we have excluded that there is some kind of injury, there is some kind of infection, there is some kind of trauma. We have excluded everything else, and the only thing that it could be is the drug. All right. So drug-induced disorders are a diagnosis of exclusion. We've looked for everything else. We can't find anything else. It must be the drug. It's challenging to determine how often this occurs because there's a wide range of presentations. Some people can have very mild symptoms. Some people can have very severe symptoms. And then all the possible causes that we can't just test for with yes or no tests, right? And then there's no specific laboratory tests that can definitely prove that a drug did the damage. All right. The prevalence is relatively rare. So when you're out at your IPI sites and your API sites and your practice sites, know that this is relatively rare. When somebody comes to me and says, oh, I think this is an adverse drug reaction, what do you think? I'm always very skeptical. All right. I always look at it through a skeptical lens, like, what are we missing? Like, does this make sense? Because they always want to blame stuff like hyponatremia on drugs. And like, no. So do be mindful that it is very relatively rare, and we do need to pay close attention to that. So what should we do when we suspect drug-induced GI disorder? I want you to think about your PPCP model, right? Y'all learned the PPCP model? Yep. Okay, great. So you're familiar with this, where we start at the collect and assess, we plan, implement, and follow up. So when we suspect that, we're going to start the PPCP model. We're going to start collecting information. We're going to assess it. We're going to make a plan based on that. We're going to implement that plan, and we're going to follow up. All right. So if the patient has unexplained symptoms, labs, or imaging consistent with a GI disorder, we start collecting more information to see if it's drug-induced. So for the collect, we want to make sure that we're getting a thorough history. All right. It's really important to know as much as possible to see if we can connect the dots and align the timeline. So we're going to collect the HPI, the history of present illness, the past medical history. We're going to collect the surgical history, the social history, the medication history. Medication history should include prescription drugs, over-the-counters, herbal supplements. We're going to collect the allergy history. Right? This shouldn't be new to you. This should be review, right? For the objective stuff, we're going to look at the physical exam findings. We're going to look at organ-specific lab values to identify injury or dysfunction. For the liver, we're going to look for, if we're looking for liver injury, we're going to be looking for
AST and ALT.
Yeah, AST and ALT indicate liver injury. What labs indicate liver dysfunction?
INR and PT.
INR and PT are some of them, yes.
Albumin and platelets also.
I'm sorry, albumin and what?
Platelets.
Yeah, albumin, platelets, great. Bilirubin. What lab values indicate pancreatitis, pancreas injury or dysfunction?
Specifically lipase. Amylase too?
Lipase, potentially amylase. Yeah, great. We're going to check drug levels if we're able to, and we're going to look at imaging results. After we've collected all that information, we're going to assess. We're going to exclude any alternative etiology. So we're going to look at the hepatitis titers potentially and see if they have an active infection or chronic infection and rule that out. We're going to look at the imaging to rule out things like gallstones, making sure that their triglycerides are less than 1,000, right? We're going to make sure that we have that list of medications, both prescription, over-the-counter, herbals, and alcohol, and when they were started, when they were stopped, how long they've been on them, how they're taking them. We're going to review drug information resources to identify if the patient has, and if any of these medications are associated with liver disease or pancreatitis. And we can use a classification system like the Naharo algorithm to assess the likelihood. So this Naharo algorithm is not specific to drug-induced GI disorders. It's specific to drug-induced adverse drug reactions. So you can use this for any drug reaction, any reaction that you suspect is drug-related. Don't think about this too much, all right? If the answer is not clear in the case, then don't know. All right. If the answer is clear, yes or no, answer yes or no. But if it's not clear, don't try to force it. This is just FYI that this is available for you to use as a scoring tool to kind of give you the probability of a reaction being drug related. If it's greater than 9, it's definitely related to the drug. If it's 5 to 8, it's probable. If it's 1 to 4, it's possible. If it's 0, it's doubtful. So again, a lot of students try to force something when they don't know. They're like, well, I have a little bit of information, so maybe it's yes or maybe it's no. And they go with yes or no instead of don't know. But this is available for you to use to see if something falls in line with being drug related. We have the plan, implement, and follow. So if we determine that it's highly probable or possible, we can discontinue the offending agent. We're going to provide supportive care for the patient. We'll monitor for improvement. We're going to educate the patient. We need to specifically tell the patient, we stopped this medication because we think it injured your liver. We stopped this medication because we think it caused your pancreatitis. We need to be very clear about that to them so that they understand why that medication was stopped and they can put it on their allergy intolerance list. We might need to evaluate whether they need a different medication. So if it's a blood pressure medicine that's causing liver disease or pancreatitis, we're going to have to find a different blood pressure medicine because they can't be walking around with high blood pressure, right? Okay, so we're going to have to find an appropriate replacement, and then we can report the adverse event to FDA MedWatch. First, we're going to talk about drug-induced liver injury, so DILI. So again, we're going to exclude all other causes of liver injury. Drug-induced liver injury is not a common diagnosis, even though everybody wants to blame their liver injury on statins, like 100% of the time. We want to consider alternative causes like viral hepatitis, and if the patient has risk factors for viral hepatitis, looking at the lab values for hepatitis A, B, and C, and determining if they have an active infection or a chronic infection. We want to consider autoimmune hepatitis, which is evaluated with an ANA and globulin levels. Diagnosing that is beyond the scope of this lecture. We want to look at ultrasound and other radiology. So we want to make sure that there's no gallstones, there's no obstruction going on. We want to make sure that there's no cirrhosis, fatty liver changes, or blood clots, thrombosis in there. If all of this is negative, then we start going into a history of all the drugs that they're taking, including the starts and stop times, over the counters, and herbals. Right? So after all of this is negative, then we start looking at drugs. Epidemiology of DILI is about 15% of all acute liver failures. There are many medications that are associated with liver injury, and it's one of the common reasons for medications to have regulatory actions by the FDA, including black box warnings and removal from the market. So most common drugs that are implicated is acetaminophen. This is high doses, either acute, like so you overdose, or chronic use of high doses. So you're using over 4 grams daily for a long time. Anti-infectives, isoniazid is very damaging to the liver. Ketoconazole is very damaging to the liver. So we do need to be mindful of that when those patients are on those drugs. And then RTIs and NRTIs can be damaging to the liver. Anti-epileptics like valproic acid. And then amiodarone has a lot of black box warnings for a lot of organ failure. So liver, thyroid, lung. Chronic hepatitis or alcoholic hepatitis is also a very common cause of drug-induced liver injury. So we want to make sure that we're collecting a careful history on their alcohol use. Herbals and dietary supplements. Milk thistle is another common drug that people buy over the counter, or a supplement that people buy over the counter that can cause liver damage. How do these drugs cause liver damage, liver injury? There are different ways. There's intrinsic, which include autoimmune, cell membrane injury, CYP450 related injury, mitochondrial injury. And then there's idiosyncratic. We just don't know why is causing liver injury, but it's causing the liver injury. Don't get hung up on this slide. This is a nice to know. So when we're looking at the drugs and trying to figure out whether they are possible causes for DILI, Micromedics and Lexicomp are generally the package insert, and package inserts are not updated on a regular basis. They're only updated when there's major findings. So Micromedics and Lexicomp may not have adequate detail. They may not have enough information. They may not have the most up-to-date information on liver injury. So you're going to want to check liver tox. This is created by the National Institute of Diabetes and Digestive and Kidney Diseases in the National Library of Medicine. It's a free resource and it has detailed information of reports summarizing the information. So liver tox is the most comprehensive to determine whether a drug causes drug-induced liver injury or not. You can, if you don't find anything in liver tox, then you can look in PubMed for any recently published cases. Of note, liver tox was updated as recently as December 2024, so it is pretty up to date. But do be mindful that this is part of the NIH, and depending on what happens with Senate confirmations and how the NIH chooses to operate under this administration, that it may not be as reputable as it has been historically. Luckily, I don't think there's anything controversial about liver injury or kidney, so hopefully it will be maintained. We can assess with imaging and biopsy. See? Our plan, implement, and follow-up. Obviously, if we think that the medication is causing the issue, we're going to want to stop the medication. Especially if the LFTs are greater than 3 times the upper limit of normal. So please remember that greater than 3 times the upper limit of normal is cause for concern. Whether that be lipase, whether that be AST or ALT. Reminder that we should avoid NSAIDs in patients with cirrhosis. We want to assess the severity of the disease. We don't want to re-challenge. We want to make sure that we're providing supportive treatment. So if a patient overdoses on acetaminophen, we can give them N-acetylcysteine. If they have high valproate levels, we can give them carnitine and then follow up. We talked a lot about alcohol causing cirrhosis. So alcohol-associated liver disease can lead to fatty liver, alcoholic hepatitis, and chronic hepatitis. All right, and that which ultimately leads to cirrhosis. The risk of this increases with the duration, so how long you've been drinking alcohol and how much you are drinking alcohol. Women have much higher risk for alcohol associated liver disease than men. The fatty liver part is reversible if you stop drinking. Chronic alcohol use leads to pro-inflammatory status with cytokines, which lead to inflammation, apoptosis or cell death, which then leads to fibrosis of the liver cells. The liver can regenerate to some extent, but most of the time people are out drinking their regeneration. So our plans, if our DILI is due to alcohol, is to stop drinking alcohol. That can be very hard to do. So we want to control cravings with benzodiazepines, inpatient, outpatient. We've been known to use gabapentin and topiramate to control cravings. And then we want to prevent relapses. So naltrexone, acamprosate, and disulfiram are all drugs that make drinking just not appealing, or disulfiram actually makes you very sick if you drink while you're on it. So we want to prevent the relapses and potentially a support group if available. Because excessive alcohol use leads to poor nutrition, patients with alcohol use disorder often have vitamin B1 or thiamine deficiency, which leads to Wernicke-Korsakoff syndrome, which is a change in mental status. They are often have altered mental status, or are just seemingly off mentally. So we need to make sure that we're replacing their vitamin B1. And they often get folic acid and a multivitamin with B1. So if somebody's admitted with alcohol intoxication, they get a banana bag. Has anybody made a banana bag at their IPI site or at their work site? Jesse has. So a banana bag is thiamine, folic acid, and multivitamin to help prevent complications from Wernicke-Korsakoff. All right, so moving on to drug-induced acute pancreatitis. There are hundreds of medications associated with pancreatitis, but the incidence of drug-induced pancreatitis is 0.1 to 2% of all pancreatitis. So that is very, very low, y'all. All right. Drug-induced pancreatitis is often idiosyncratic, meaning that it's not identified in clinical trials. It's difficult to rule out other causes of pancreatitis, and there's no mandatory reporting and lack of high-quality studies. So it's very, very challenging. There are several mechanisms for drug-induced pancreatitis. We have idiosyncratic, meaning that we don't know what's causing it. We see structural, toxins, metabolic, and immune-related. We're going to go all of these into detail on all of these on the next couple slides. So idiosyncratic is the most common, not related to the mechanism of the drug. We don't know what happened. Patient took the drug, it caused pancreatitis. Structural is when something gets in the way of that sphincter of Oddi that we talked about. So that can be gallstones. So drugs that increase the risk of gallstones. So ceftriaxone causes the production of sludge or stones in the gallbladder. This is why we can't use ceftriaxone in newborn babies, because newborn babies' liver doesn't work very well. So they can't metabolize the ceftriaxone and it gets all junked up in their liver. But that can happen to adults too. Statins can also cause gallstones because we increase the amount of cholesterol secreted in the bile. And then if the bile has more cholesterol, it's more prone to create gallstones. So statins can cause gallstones, which that gallstone gets stuck in that sphincter of Oddi, can cause backup and cause pancreatitis. We have medications, much like medications that affect our lower esophageal sphincter, we have medications that can affect that sphincter of Oddi and make it too loose and too open and let fluids go back and forth. And so macrolide antibiotics have a prokinetic effect, especially like clarithromycin and erythromycin. So they're going to help the motion of that smooth muscle in the GI tract, increasing the pressure on the sphincter of Oddi to have stuff flow back into the pancreas. NSAIDs, inhibit prostaglandins and they cause pancreatic duct dilation. So that sphincter of Oddi is going to dilate, again, that allowing that backflow. Solindac is the most common studied NSAID that causes this. Luckily, we don't use Solindac very often, but other NSAIDs can cause it. Drugs can cause toxins. So toxins, if we think it's drug related and it's a toxin drug, it's not going to show up on the first dose. It's going to show up after weeks to months of use. All right. It's a cumulative effect. So all those toxins are adding up. They don't add up in one day. They add up in weeks to months. So metronidazole, we think, has free radicals that are toxic to the pancreatic cell. So if somebody's on oral metronidazole for prophylaxis, that can be problematic. Valproic acid is a mood stabilizer, also used for seizures. So this is a chronic medication. Again, potentially free radicals. All right. So it's not going to show up on day 1, day 2, day 3. This is going to show up weeks to months later. All right. There are drugs that have metabolic issues. And so drugs that cause hypertriglyceridemia, again, triglycerides have to be over 1,000 to increase your risk of pancreatitis. So drugs that increase our pancreatitis are conjugated estrogens. So think about women, or not just women, but people who are on hormone replacement therapy, who are on estrogen, like Premarin, right? HIV protease inhibitors. So thinking about patients with HIV, because most patients with HIV are on a protease inhibitor, and thiazide diuretics. But it's not just enough to be on the medicine. Their triglycerides have to be over 1,000 too. So they're on conjugated estrogen and their triglycerides are greater than 1,000. That increases the risk of pancreatitis. They're on hydrochlorothiazide and their triglycerides are over 1,000. That's the risk for pancreatitis. There are drugs that can cause hypercalcemia, so too much calcium in the blood. So thiazide diuretics. So thiazide diuretics are a double whammy. They can increase your triglycerides, they can increase your calcium. Vitamin D can increase your calcium. And calcium supplements, especially if you're getting an IV supplement, can increase your calcium. But again, for these to cause pancreatitis, your calcium has to be high. We have
Is
oops. Go ahead.
Is arteriosclerosis easy to get with vitamin D? Because I feel like since vitamin D deficiency is so common, it's easy also to overdo it. Is that a problem that you guys see in the clinic?
No, most everybody is vitamin D deficient. There's a lot of controversy over what vitamin D deficiency is and like what the threshold is. So I rarely see anybody who's overdosed on vitamin D, even if they're taking extra.
Okay.
We have immune mediated, so ACE inhibitors. ACE inhibitors, one side effect that we're really concerned about is angioedema, swelling of the lips, swelling of the tongue. Do you think that those are the only places that swell when you have angioedema? No. So angioedema can occur in the pancreatic duct, leading to obstruction, which can lead to pancreatitis. So you would see this on imaging. You would see it swelling in the pancreas on imaging, and that was going on. You would also see gallstones and sphincter of Oddi dysfunction on imaging. This one would also show up on imaging. But toxins aren't going to show up on imaging, and metabolic are not going to show up on imaging. So we're going to assess to make sure that the presentation is with acute pancreatitis and that we've ruled out gallstones, we've ruled out alcohol and tobacco use, trauma, obstruction, hyperlipidemia, chronic hypercalcemia, ruled out infection. We've ruled out all those common causes. Nothing makes sense. It could be the drug. We're going to treat the pancreatitis. We're going to treat with fluids. Which fluid are we going to use?
Lactated ringer.
Lactated ringers, great. Nausea, vomiting, and pain management. What type of IV or PO? IV. All right. And we're not going to re-challenge and then monitor for them for improvement. All right. So those of you that were interested in drug-related adverse reactions, you should take a deeper look at that Naharo algorithm that can really help you determine if any reaction is related to a drug. And I'm happy to spend more time talking about it. We'll probably have some time tomorrow to talk about it some more if you want. But for tonight, what I need you to do is review the information on the presentation. There are cases and articles posted on Canvas, and there's a quiz for you to do. Oh, I need you to do the quiz tonight. You can work in groups. Everybody has to submit their own quiz, but you can work with a partner. You can do it by yourself. It just needs to be done before class tomorrow, whatever time we start class tomorrow. All right. You can open book, open note. I think there's 17 questions based on the case. Let me just I don't know if yours looks the same as mine, but you have the cases here, and then there's a PDF of each of the cases, and then the articles, and then the quiz is right here. There's two different ways to format quizzes in Canvas, and I formatted this quiz a different way. So let me know as soon as possible if you're having issues, because I've never worked with Canvas before, and I can look at it from your side, like from a student view, but I don't know if that's truly like what you're seeing. So please let me know if you have any issues. We're going to talk about all the answers tomorrow. I'm having you do this as homework because I used to give you an hour in class to do it. And I found out that for some people, that's not enough time. And I want to make sure that you have enough time to think about it. So that's why I'm asking to do it as homework before class. That way we're making the best use of our time in class tomorrow. So that's why it's homework now. All right. What questions, concerns, comments do you have for me? Okay, so be prepared to discuss those tomorrow in class. It is due like right as class starts, so please do not, delay in getting it done. And again, let me know if you have any issues right away. I'll take any questions you have about this topic, comments, concerns. We will be on Zoom again tomorrow. All right. Again, the quiz is due tomorrow before class.